Welcome back to the Girlfriend Doctor Show, Kim. It's great to have you here.
Nice to be back. Nice to see you.
Nice to see you. I want to see you in person again.
I know. Hopefully soon.
Hopefully soon. Any more trips to Dallas coming up?
No, not anything planned, but I do want to come back. I love Texas. I loved it when I was there. And obviously seeing you was really great. But yeah, we'll have to plan another trip.
We'll have to, yeah, definitely. And I'll get you on the horses next time.
Yes.
So good. And so what I wanted to really dive deep in today is to talk about what happens in menopause and beyond post-menopause with our pelvic floor that's creating the issues of prolapse and incontinence and discomfort that so many of women struggle with, including myself, had struggled with during this time period, and how we can, you've created amazing solutions, whole programs to help us strengthen. I love that you call it Buff Muff. And so let's talk about that. Okay, what is the Buff Muff?
Yeah, well, it's a fun way to talk about a different difficult topic. Like it's pelvic health is not sexy. It's not fun. It's nobody wants to talk about it. There's a lot of shame, embarrassment. There's a lot of emotion tied with it, and anger, resentment, everything. And so while I appreciate proper anatomical terminology and definitely do use it because we need to know our anatomy, I also think we need to lighten the load, literally and figuratively, when we're talking about pelvic health. And so
we get banned talking about pelvic anatomy.
Oh my gosh. I for years never could, vagina was inappropriate. And even still, I have to be careful with what I show and what I say. And so one day I had created this 28-day pelvic floor fitness challenge. And I took a picture of myself flexing my arm muscle, and I had my vulva puppet in my hand. And I said, who wants to buff their muff? And it just was like, I said it just kind of as a fun joke. And then people said, oh, ha, so funny. And anyway, that I ended up calling my whole program that because people like the name so much.
I love it. I love it because it gives you a sense of humor, and it's, this is something that's fun, and it takes away some of the taboos around it, but yet it's still quite a taboo topic.
Yeah, absolutely.
And it's a big issue, and there's a lot of shame around the pelvic floor, post-menopause, incontinence issues, prolapse issues. And I would love to talk about that with you today, and what you're seeing and how you're helping women. Well, first of all, some of the structural changes that are happening post-menopause.
Yeah, what with the explosion of the conversation around menopause, the good thing is it is indirectly fueled more conversation around pelvic health, because we have this whole subset in the umbrella of menopause. We have genitourinary syndrome of menopause, which is the collection of signs and symptoms that affect the vulva, the vagina, the bladder, the structures within our pelvis. And a hallmark of that,
with that genitourinary symptom of menopause, they, forget about the anal area, the anal tissue.
Yes.
There's hemorrhoids, things like that happen, but that is part of that.
Absolutely.
Syndrome.
Yeah. And so a hallmark of that is this loss of estrogen. And so that is a big part of this conversation, is hormones and estrogen. And I don't want to take away from that, because it absolutely is it is a major contributor to many of these signs and symptoms. However, we can't discount that there have been many years that have led up to this. And usually menopause is sort of a culmination where the loss of estrogen is almost like the straw that broke the camel's back. So up to that point, there usually have been signs and symptoms along the way that people may have experienced, and maybe just sort of they could brush it off. They could wear a pad. It wasn't that bothersome. It only happened a few times. It wasn't, and they can excuse it away. We have years of age-related muscle loss, sarcopenia. We have changes to our bone structure. We have loss of hyaluronic acid, loss of collagen, as well as our hormones as well. And so we come to this point of perimenopause, menopause, where it's the culmination of all these things, where it's like the tipping point is now we have the loss of estrogen, and now it's just like everything is exaggerated. So it could be that they've been dealing with little symptoms along the way, and all of a sudden now it's the body is screaming much louder, or it's when the symptoms show up for the first time, and maybe they weren't symptomatic before, but now again, because of all of the things that have led up to it, then it shows up. But the other thing that one thing that I talk a lot about is the fact that pelvic floor symptoms. So it could be incontinence, could be organ prolapse, could be low back pain, could be painful sex. Pelvic floor dysfunction is a reason why 1 in 2 women will stop exercising.
Mm-hmm.
And so the sedentary lifestyle is another piece of that has then also contributed to many more years of not moving our body in ways that would support the pelvic floor. So I think that it's a time of life when we can pay more attention to ourselves. It's a time of life where sometimes maybe if we're in a partnered relationship, we have more time, but now with that more time, if we're experiencing some sort of sexual activity, it now is uncomfortable or it's hurting. And many people have paid attention to other people in their lives, little people that they've been raising, their jobs, their whatever it is. And now all of a sudden they may have a bit more time to pay attention to themselves. And as they pay attention, they now realize that I'm actually really suffering here, and they don't necessarily recognize all the little things that have built up along the way that have contributed.
That's a really good point. Again, you've been powering through so long. And as women, we power through in so many ways. We get up at, 4 a.m. if our children need us, or if we're on call, or whatever the situation may be, that we just power through our exhaustion or fatigue. We power through ignoring our symptoms. And it's like, that has to stop. That has to stop.
Yeah. And when it's a part of the body that is already, as we've just said, we feel uncomfortable talking about it. We're ashamed. We're not being asked by our care provider anything about it. So when we and if we see on the ads on TV that say it's just part of being a woman, then we just sort of feel like that's what we're supposed to do. We just power through. We just have to suck it up. There's nothing that can be done. Or we've heard that, you have to have surgery for this, and I don't want surgery, or I'll just wait till it's really so bad, then I'll have surgery. So I think we get mixed messages if it's even talked about at all. And it is also difficult to talk about. And we have some studies that look at about 6.5 to 7 years that women will struggle before they ask for help. And the challenge,
I would say, at least.
Yes. And the challenge then at that point is when they finally do ask for help, the person they typically go to is their family doctor, which I don't want to take away from the medical community, but their training is pharmaceuticals and surgery. So they're either referring on to a specialist for pharmaceuticals or surgery, or even prescribing overactive bladder medication, or go home and do your Kegels.
Yeah, the overactive bladder medication. I'll touch on that for a second, because that has so many negative consequences. Increased risk of dementia, Alzheimer's. I mean, and worsening, it creates dryness, dry eyes, dry mouth, dry vagina.
Constipation.
The problem. Yeah.
Constipation, which is another contributor to pelvic floor dysfunction. And many women so many women are struggling with constipation, and that's the reason why they have pelvic floor dysfunction. And so then if we give them overactive bladder medication that makes them more constipated, there's no root cause investigation that happens within those 5 to 7 minutes you have with a family physician. And that's the system they work within. And it's also the limited training they get within that specific aspect of health. And so we deserve and need better care, more care, and more screening. So I always recommend you see a pelvic floor physical therapist as your first line of defense for a much more thorough evaluation. If there is something beyond what they can help identify that is medical, then you would go to your medical team for that. But I just see so many people put on medication needlessly, who then now have this whole host of other symptoms that they need to deal with that are often exacerbating what they went for help for in the first place. So it's unfortunate. I hope that at some point in my lifetime, we see that we have this information given to young people when we're teaching them about menstrual cycles and sexual health and bodies. Why aren't we talking about the importance of this part of the body called the pelvic floor, and that there are specialists that help us? And once we become sexually active, see that person once a year for a checkup. I just think it would literally change the world and change women's health for the better.
You're absolutely right. And you were saying that, one of the main recommendations that we give too is go ahead and do pelvic floor exercises or Kegel exercises.
Yeah. And limit. I don't want to take away from Dr. Kegel, who designed this exercise in the first place. And he was witnessing women experiencing challenges, mainly postpartum. And he used a biofeedback device to help women connect with their pelvic floor because it's part of the body we can't see. And again, nobody's been given any education about it. So he came up with how we can voluntarily activate and relax this group of muscles. And he called it the Kegel after his last name. What's happened over the many years since he named this exercise is it's been misinterpreted. We have this belief that we need a tight vagina. We need to Kegel so hard and so strong. And we also show that most people do Kegels incorrectly, again, because they've never been taught. And so if this person who finally seeks help, either, maybe they are offered medication, maybe not, or maybe they're just told, go home and do 300 Kegels a day. Usually either just saying that or giving them a brochure, we know that's not helpful. And most people do them incorrectly. So then they're either making the situation worse or it doesn't help at all. So then they say, well, this doesn't work. And so, well, I guess this is just what I have to live with for the rest of my life. But there's so much more than Kegels, and most people interpret it as a squeeze, and they often squeeze their inner thighs or their glutes, or they sometimes even bear down thinking they're doing a Kegel. But we need to evolve from there. We need to expand upon this, well-intentioned exercise, and also realize the limitations of it, where we typically are experiencing pelvic floor symptoms when we are moving, when we stand up from a chair, when we exercise, when we lift our grandbabies, when we're laughing. It's not when we're sitting in a chair or lying down on the floor or in our beds. So if we're only doing Kegels, even if we did them correctly, sitting in a chair or at a red light or in bed, that doesn't train us for the upright movement that we do in a day. We need a dynamic approach to pelvic floor fitness training. And so seeing a pelvic floor PT who can evaluate you in various positions, including an upright position, where the presentation of your organs, the ability of your muscles to contract and relax will be different than when you're lying down on your back. And also then committing to movement practices that incorporate the pelvic floor in a way that supports that, the activation and the relaxation of the pelvic floor muscles with our breath. That is so much more robust and will translate more into success and results compared to just doing 3 sets of 10-second hold Kegels every single day.
And when we talk about the pelvic floor evaluation, can you walk through a PT pelvic floor evaluation?
Yeah, I think it's one of the most underused women's health resources that we have. And a pelvic PT, depending on where you live in the world, it might be called a PT, a physical therapist, or a physiotherapist, maybe called a women's health physio or physical therapist. These are people who have taken, they've become a physical therapist, and they have then taken additional training in the pelvic floor. So they are licensed to evaluate and treat beyond the opening of the vagina. Rectally sometimes may be indicated. Most of them work with women. Some will work with men, because men can have pelvic floor challenges as well, not to the same degree that we do as women. And in that session, typically the first session is about an hour. And the majority of it is a health history conversation, understanding your symptoms, understanding your birth history, your sexual health history, your movement and activity. What do you do on a daily basis? All these things that some people don't necessarily associate with what they might be dealing with. Then if time allows, in that first session, there may be an internal evaluation where you would be lying down on a treatment table. The PT would be evaluating with gloved fingers, looking at the external genitalia, looking for scar tissue, looking for changes to the skin. An important point to mention is the changes associated with menopause can lead to symptoms of itchiness, burning, redness, bleeding, sometimes with any sort of insertion. And some of those symptoms also mimic a condition called lichen sclerosis, which is a vulvar condition, an autoimmune condition. And having somebody to screen for that is important, so that you don't, maybe you do have lichen sclerosis, but you're associating it with the changes of menopause. So it's important to have somebody who's looking, including yourself. And then with an internal evaluation with your consent, the therapist would part the labia. They would see if you can accommodate insertion of one finger. Could you allow for a second to be inserted? Is there any pain? They are assessing the tone of the tissues. So is one side maybe more restricted in movement than the other? Is one very lax? One's a very high tone. They would want to look at the position of the organs. They would ask you to cough or bear down to see if there's any descent of those organs. They would ask you to do a Kegel or an activation to see if there's a balanced squeeze, lift, and can you release that tone? And ideally, that person would also then take you off the table and assess you in standing as well. So the finger or fingers would still be inserted in the vagina, and they would ask you to maybe cough, do a squat, just do some sort of movement to see how your pelvic floor is responding to your movement and changes in intra-abdominal pressure. So that's kind of very high level. I have a couple of videos on my YouTube channel as well that walk you through what it would look like using my vulva puppet and also another anatomical model.
That's excellent. I mean, it's a good understanding. And I think in some cultures, post childbirth, they receive pelvic floor physical therapy. I know France is one of them.
Yep.
That the women postpartum will have a part of their postpartum paid by the government, pelvic floor physical therapy. So
yeah, it's usually 6 to 12 visits, and I've spoken to women. I've spoken to the therapists that provide it, who are in France. I've spoken to women who've had the therapy, and I would say it's, it should be global. It should be something that all parts of the world are doing. It would save healthcare billions of dollars, honestly, if we were screening. But it's placing an importance on, some people say, oh, it's just because of sexual health. Yeah, that's one component of it, but there's so much more than that. And when we think about how much the optimal functioning of our pelvic floor dictates how well everything else in our life goes, then we start to place a different value on it. And it is absolutely not just for sexual health. However, I do want to say that is an important part of our wellness, is our sexual health and our pleasure. So us having a well-functioning pelvic floor and having somebody helping us care for it, especially postpartum, when we know that there's been disruption to our tissues, is so valuable.
Yeah, no, I agree completely. And again, that's, even in medicine, pelvic floor physical therapists are underutilized.
Yeah.
I think so many women can benefit from pelvic floor PT, and important thing to talk about, ask, and it's often covered by insurance. It's often covered by insurance too, as much as I don't like insurance companies, but it's good to know that it
is. And that's, I agree with your statement. However, it is something that does, reduces one of the barriers, I would say. If somebody can have it covered by their insurance, then that is removing one barrier for some people.
Yeah. And with that, again, we talk sexual health, keeping the pelvic floor, the anatomy, the nerve supply, the blood supply, vital and functioning at its optimal. That's a key part. And bladder health, the incontinence issue, again, it's estimated that up to 85% of women post-menopause will struggle with incontinence. And we know that it's like the devastating triad is when a woman gets up in the middle of the night to use the bathroom, because it's just nocturia, getting up at night a couple times, trips and falls, breaks her hip. And now she's further immobilized using a walker or having rehab, and then continued incontinence issues. Then that's like often the straw that breaks the caregiver's back. And then nursing home care. And then it's estimated within 6 to 8 months, that's the life expectancy of that individual after that event. And it's tragic. It's absolutely tragic. So like you said, costing society billions, but the quality of life and losing these amazing matriarchs and this beautiful, this beautiful elder population. It's so critical that we look at this, talk about it, and not say it is normal for your age. And that is unacceptable.
1,000%. And we need to be like, I look at this through a lens of longevity and aging powerfully, and the pelvic floor being such a catalyst for our ability to age powerfully. Because like I said, with that one study or statistics, where 1 in 2 women are stopping exercise because of their pelvic floor dysfunction and becoming sedentary. Being sedentary is also a risk factor for pelvic floor dysfunction and constipation. And constipation is a risk for pelvic floor dysfunction. So we get into this hamster wheel. And if we can keep women moving and moving well and moving in ways that supports their pelvic floor, but also leveraging the pelvic floor so that we can lift heavier weights, so that we can do the impact that is helpful for our bones. Also, from a balance perspective, you mentioned falling. It's waking at night is one of the big contributors, but just we lose more type 2 muscle fibers, the quick react. So those quick react fibers are the ones we need to help us stop the urine, but it's also what we need to help us stop if we trip or if we tumble. So training, again, in the limited lens of do 3 sets of 10-second hold Kegels versus let's bring this into whole body movement where we are training for strength and endurance and power and explosive movement and things that will help keep not just our pelvic floor working well, but the rest of our body aging powerfully as well. We're going to reduce those risks of falls and osteoporosis and heart disease and the other health challenges we face that are increased, especially in that post-menopause phase of life as well.
And core strength, right, is necessary for good pelvic health.
Well, the pelvic floor is the foundation of the core, and that's never been communicated. I'm a fitness professional. I have taken oodles of fitness courses. Never, ever has the pelvic floor been mentioned, yet it is the foundation of our core. So I've heard about core exercise, and we learn the abs and the low back, but we forget about the breath and the pelvic floor, the diaphragm and the pelvic floor. So that's what I call the core 4 unit. And so, so core, a strong core is a strong pelvic floor. If you have a strong pelvic floor, your core strength is going to improve.
And if we look at the pelvic floor, it's also been named the pelvic floor, but it's really pelvic sling or pelvic bowl.
Mm-hmm.
When we think of it extends, the extension of the pelvic floor, it goes beyond the floor. It goes beyond the floor of our anatomy. So what does a good pelvic health regimen look like?
There's lots of different things, and I'll name off a few that I consider to be essential. So one would be hydration. We need to make sure that we drink enough water. And a lot of people who deal with pelvic floor dysfunction limit their water intake or fluid intake in general because they think that will help stop the leaks, or then they won't get the strong urges to have to go. When you drink less water in particular, and if you're also consuming bladder irritants, you're going to need to go more often. The bladder is going to be irritated. It's going to send you stronger, more urgent signals, and you'll get into the habit of then now peeing just in case or planning your life around the bathroom. So drinking at least half your body weight in ounces of water per day is bare minimum. I usually say 2 to 3 liters of water throughout the day. That then leads into number 2, which is constipation. Constipation is a major, major contributor to urgency, urinary urgency, urinary frequency, and the development of pelvic organ prolapse or the exacerbation of pelvic organ prolapse. And so many women, especially in that perimenopause transition, struggle with constipation. Sometimes it's hormone related, sometimes it's thyroid related, sometimes it's both of those things. Sometimes it's sedentary. Maybe they've been leaking for a little bit and now they're not moving as much. And so now they're sitting more, and then without moving, now we're going to get more constipated. So those 2 things always come first. I could give you all of the other fancy exercises, but if you're dehydrated and not pooping and you're straining every single day, you're really going to kind of do 1 step forward, 2 step back. You're never going to make the progress that you need. So you have to optimize those 2 things first. Next would be your alignment to your posture. You want to make sure for that inner core system, that diaphragm, pelvic floor, abdominals, and back, we need our body position, the alignment of our rib cage over our pelvis to be optimal so that relationship can happen optimally. Then we have to look at retraining the system. So many people have some sort of dysfunction for whatever reason. It could be posture, it could be pregnancy and childbirth, it could be previous pelvic surgery, it could be a fall on the tailbone, it could be trauma, it could be fear. So many things can contribute to symptoms. And that symptom, like there's some sort of disruption to that inner core system. So we need to retrain it. So we work on our alignment. We work on our breath. I call it the core breath, where we understand the influence and the relationship of the diaphragm with the pelvic floor. And we use cueing and imagery. So I always think of the inhales as like a jellyfish softly floating or expanding in the water. You can think of blossoming your vulva on an inhale. And then the exhales, you think about picking up a blueberry with your vagina and your anus, or sipping a smoothie through a straw with your vagina. So that's retraining the core kind of pelvic floor diaphragm relationship, bringing in the imagery to help us access this group of muscles that we can't see. Then the final step would be coordinating that into whole body movement. So once we have practiced this breath, we understand how to voluntarily activate and relax our pelvic floor. We then want to bring that into this philosophy of training the pelvic floor dynamically and bring it into a movement like squats or lunges or push-ups or bicep curls, overhead press, a lot of things that you would see in other in gyms or other workouts that you might be doing. But let's harness the pelvic floor as part of that with our breath, so we are better able to manage intra-abdominal pressure. Exercise and many things increase intra-abdominal pressure. And also when that center, our core, our pelvic floor is working well, we often can generate more power. We can lift heavier. We can last longer in our fitness routines. We don't have as much discomfort in our backs. 95% of women with low back pain have some form of pelvic floor dysfunction. And we see all these other practitioners, but we forget about the pelvic floor. We forget about the pelvic floor physical therapist. So those would kind of be like my highlight of those, hydration, constipation, alignment, breath, and coordination. Those are the main steps. And that doesn't have to take 5 hours a day. We drink water throughout the day. Make sure you're eating and drinking in ways that make sure you have at least one good bowel movement, Bristol stool chart number 4 every day. And then
Dark
the
brown
ABCs.
banana.
Yeah, yes, exactly. And then the ABCs, alignment, breath, coordination, that can be your workout. It doesn't have to be a pelvic floor workout and your other workout. You're incorporating it into the same thing. And training for balance, training for power, training for reducing fall risk, training with resistance, training with impact, and you're bringing your pelvic floor into all of those.
So, and it's often counterintuitive. I do want to talk about constipation for a second. I'm glad you said at least one dark banana brown, dark brown banana stool, right? You get an idea, and you usually say your forearm length is a good emptying indicator. And when because I have questionnaires, I've interviewed thousands of patients, and sometimes I'll be like, okay, nope, no constipation. I'll do an exam. I'm like, for sure, you have constipation. I mean, how often do you use the bathroom? And they say, oh, 2 to 3 times a week. I have a bowel movement 2 to 3 times a week. And I was like, okay, you're constipated. So like, I've been this way all my life. We're going to fix that, right?
Yeah.
You're going to fix that, because that creates a lot of dysfunction. But oftentimes people don't even realize, because this has been going on so long, that they are constipated by definition if you're not having at least one good, healthy bowel movement every day, preferably 2 to 3. And so that's I think it's just awareness that even if you've been suffering it all your life, it doesn't take long to reactivate the colon and get those bowel movements going, and understanding this part and how important structure, alignment, hydration, nutrition, et cetera, is critical to healing that. The coordination piece. Okay, now you're asking me to pat my head and rub my belly at the same time, basically. And this coordination piece with exercise is very counterintuitive, because I'm a gynecologist. I've been studying this for a long time, and I was trying to figure all this out early on. And I'm like, okay, wait, intuitively, I'm exhaling when I should be inhaling, and I'm holding my breath when I should be exhaling. And so help me with this. Okay, I'm doing squats or lunges, and how am I, how do you recommend we incorporate that coordination of the pelvic floor during that? I need to know this.
Yeah. We need to step back and just focus on the breath to start out with. So that's why the breath comes before the coordination, because if I tell you how to do it and then I put you right into a squat, that is, people are like, what, am I inhaling? Am I picking up a blueberry? Am I letting the blueberry go? What am I doing? So and I will say that in my program, that I hear that 99% of the time. I feel like I'm doing it wrong. This feels hard. It feels backwards. It feels awkward. Can't I just do it the way that I was doing it before? And my answer is no, you can't, because that's probably part of what brought you here. So physiologically, when we take a breath in, if this is our diaphragm, for those of you that aren't able to see this. If you underneath your rib cage, if you were to kind of draw your fingers underneath your rib cage from side to side, there's like a dome shape, and your diaphragm nestles under there. When we take a breath in,
where my explant scars are, by the way. Just
yes,
saying.
okay. So, or where like, your bra, just underneath your bra line, you feel your ribs, and your diaphragm is a dome shape underneath there. And when we take a breath in, the lungs, which are behind our ribs, they're inflating, and ideally our ribs are expanding sideways. And what is happening with the diaphragm when that happens is it's flattening and widening. So that's what happens on the inhale. And what should happen underneath then is the belly expands away from the spine and the pelvic floor lengthens. So that's all creating space for air to come into our body. That's the whole point of taking an inhalation, is drawing oxygen into our body. When we exhale, the pelvic floor should contract and lift. The belly should naturally draw inwards towards the spine, and that flattened dome of the diaphragm rises back up into that cone sort of dome shape again. So understanding that physiologically, inhales are where the pelvic floor lengthens, exhales are where the pelvic floor contracts and lifts, that's step number one. And then you have to pattern that. So we can do that lying down. You can do it in a wide leg child's pose. You could do it seated. You could do it standing in a static position where you can focus and you can concentrate, and use that imagery. Inhale, blossom the vulva. Inhale, think about the jellyfish expanding and softly floating. Exhales are now the jellyfish is propelling up. The exhale, the flower blossom is closing. Exhale, we're picking up a blueberry. Whatever imagery is going to work best for you. So you have to pattern it initially in a static position. And then once you feel like you've mastered it and it's starting to feel a little bit more natural, inhale, expand, exhale, activate and lift. Inhale, expand, exhale, activate and lift. Now I would then take it over into the squat. And when you're thinking about adding it to a squat or any other type of movement, we want to now look at, typically in fitness, they will say exhale with exertion. So you're exhaling with the hardest part of an exercise, the lift or the push or the stand up. So in a squat, the harder part of the exercise is where we have to stand up against gravity. So inhale and lengthen is what we would be doing as we lower down into the squat. Then we exhale, pick up our blueberries, and then we stand back up. So inhale, expand as we lower down, exhale, activate, and stand back up. And the reason I say exhale to activate the pelvic floor first and then stand up, we want to activate the pelvic floor first. In an ideal functioning world, we shouldn't have to think about picking up blueberries or jellyfish, or it should just be happening without us thinking about it. But something along the line has disrupted this synergy, and we're now retraining it. So there's an anticipatory element of the pelvic floor where we know from research that it pre-contracts milliseconds before we fall, milliseconds before we cough, milliseconds before we push or stumble. It knows before we consciously know that we're going to fall. And so it pre-contracts. So what we're trying to do is retrain that anticipatory element. So we are voluntarily saying, I'm going to stand up now and it's going to be hard. So I'm going to pre-contract. Now I'm going to stand back up. And that little voluntary pre-contraction is what helps repattern that anticipatory element of the pelvic floor. So the more we do that, the more we pattern it, the more we get back to that automated pre-contraction. And ideally, people get to the point where they don't then have to think about picking up a blueberry. It's just happening again automatically.
How long does that usually take to get to that point?
It depends on how long a person has been struggling and what they are struggling with. But I will say most people who come into the program, from an incontinence perspective, usually within 2 weeks, they notice a change in their symptoms. They usually get, more comfortable with that movement within about a week or so. People who have pelvic organ prolapse, I would say that takes a little bit longer for them to notice a change in their symptoms, but usually within a month to 2.
Okay. That's not long.
No.
That's not long.
You have to take into account that, like, we want things now. I want it to change. I want it fixed. I want this. I want that. This has taken years to get to this. We just haven't necessarily been conscious of all the contributing factors. So we have to give ourselves some grace in relearning, unlearning, unraveling, And it can be frustrating, but showing up for yourself consistently for 10 minutes, that's all you need. 10 minutes a day can make a huge difference in the rest of your life. When we are not distracted by our symptoms, by our discomfort, by the pain, by the fear of leaking, by the fear of can somebody see or smell, all of a sudden we have this freedom back. We aren't planning our lives around the bathroom. We can participate in social outings. We can enjoy intimacy. We can work more productively. So give yourself that 10 minutes every single day consistently, and things will change.
I love that. Just 10 minutes a day.
Yeah. Yep.
10 minutes
Doesn't
a
take a
day.
lot.
And I said this will benefit prolapse because that is a very common condition as women age that create, a lot of consequences, the bladder issues, the constipation issues, and even making it very, very difficult to have those bowel movements, etc. So there are things we can do when we have prolapse. Sometimes we still need surgery.
Mm-hmm.
But there's so much we can do and we want to do before, if we have to have surgery, to have a better surgical result or post-surgical result. So is there anything special or specific beyond this that I know there is, because you have a whole program? Yeah, I know there is, but that we can do to heal prolapse, like structurally?
Mm-hmm. Yeah, there absolutely are times where there may be damage to the tissues and support structures beyond what exercise can fix. That being said, we still need the pelvic floor muscles to be working to help increase blood flow, to help with circulation, and to support the other organs and also perform their other functions. So even if you have prolapse where that, like, maybe you've tried pelvic floor exercise already and it hasn't worked, and or you're scheduled for surgery, keep doing your pelvic floor muscle training before your surgery. That is your prehab. You going into this with better strength will improve your outcomes. And it's also going to be what you do for your rehab. And it's also what you're now more importantly needing to do forever and ever going forward, because you now have the influence of scar tissue that you need to manage. There's been a change to the landscape. So I am not against surgery. I have had a pelvic surgery myself, but we need to investigate all of what I'm going to talk about now, the other options first. And after you've given it 6 to 12 months of trying the other things, if it's not working, absolutely go to surgery, knowing that 6 to 12 months has been a really, really good prehab, and you're set up for now what you're going to do for the rest of your life. I argue it increases your need for pelvic floor muscle training after surgery.
I agree. And also part of that prehab, which I like that you called it prehab, is vaginal hormonal therapy. So
1000%.
vulvar vaginal, DHEA, testosterone vaginally is an option too. I mean, I have experienced great results with that. I mean, as a gynecologist, pelvic floor surgeries were part of my weekly operating schedule, definitely monthly operating schedule. And as I understood hormonal therapy more and more and started using, DHEA on my patients and testosterone on my patients pre-op, start 2 months beforehand, bring them in 2 days before their surgery that's scheduled on my calendar. They're like, Dr. Ann, I don't remember I don't leak anymore. I ran 5 miles, didn't wear a panty liner, had the best orgasms. I'm like, I mean, you don't need surgery, right?
Yeah.
And it was,
and especially if the person is going to use a pessary as one of their conservative options, we absolutely need a well estrogenized or lots of DHEA, testosterone. We need the hormone support, the tissue support, the integrity to manage an insertion and removal of a pessary. So a pessary is one option for people dealing with pelvic organ prolapse. I always say, number one, go see your pelvic floor physical therapist.
Yeah.
That's your number one. From there is part of your issue. Tight muscles is part of it. Poor lifting strategy is part of it. Constipation, is it posture related? So we can address the root causes. That in and of itself can make a big difference. Then you're going to do your pelvic floor muscle training, which we've talked about a little bit here. So the core breathing with the voluntary activation and relaxation, and bring that into movement. But the one practice that, in my opinion, is what moves the needle the most with regards to prolapse, it's hypopressives, also called low pressure fitness. And this is it came about from a pelvic floor physical therapist in Belgium years ago, who was using a speculum, which is not typical with pelvic floor PTs. They don't typically use speculums, but this person was. And when the speculum was inserted, the patient who had a prolapse was a little bit startled, and there was a retraction of the prolapse. And so the physical therapist was saying, well, what was that? And investigated and ended up creating this fitness regime based on postures that we can get in that don't create a huge amount of an increase in intra-abdominal pressure. Intra-abdominal pressure is something we all have, we all need, we don't escape it. It's not that intra-abdominal pressure is bad or good. It is what it is. We just need a system that can manage that pressure. So the poses we get in hypopressives are considered low pressure, meaning they don't increase intra-abdominal pressure a lot. In that pose, we then go through a breath cycle where we have that inhale and expand. We don't add the voluntary engagement, but we just have this breath cycle that we go through. And at the end of our third exhalation cycle, we hold our breath and close off the glottis. Some people will need to keep their mouth closed and plug their nose. And then we do what's called a false inspiration. We take a breath, but because there's no air coming in because we've closed off the openings, it creates a vacuum, like a suction. And it looks like an inward, like it looks like you're really flaring your ribs and you've sucked your abdomen in. We're not voluntarily sucking our abs in. It's an involuntary response to the pressure change. And that vacuum lifts the organs, draws the abdomen inwards and upwards. And it is remarkable, especially with bladder and uterine prolapse, what it can do. Rectoceles, not quite as effective for that. They're very difficult to improve, but bladder and uterine prolapse can make a significant change. So I myself did reverse my stage 2 uterine prolapse with hypopressives. I've seen many people in like my practice and many other people who've done hypopressives who have had similar results. So it's the biggest needle mover. It's not going to replace the need for pelvic floor muscle training, the voluntary piece. The two go really well together. Hypopressives is involuntary. Pelvic floor muscle training is voluntary. We don't do the two at the same time, but is a part of our whole practice. Hypopressives is great for posture. It's great for our fascial system. It's great for building up our CO2 tolerance. There's a breath hold, and CO2, like if you've read any of the books, like from Patrick McEwen, the Oxygen Advantage, breath work helps in so many ways from a brain health perspective, nervous system regulation. So it's very powerful for down regulating and up regulated nervous system. And many people who deal with pelvic floor dysfunction have a lot of stress and anxiety specific to their dysfunction, but all the other things that they've now had to give up or feel like they need to give up because of their pelvic floor.
It's so powerful. It can be so limiting. When you talk about a hypopressive, what's a standing hypopressive posture?
Just standing in and of itself, but the way we stand, we have a bit of a forward lean almost. And it's not that you're hinging from the hips, it's that your whole body is translating forward, almost like you're a ski jumper. So if you can imagine standing upright and then your whole body sort of shifting forward over your feet with a slight bend in the knees, that's one of the standing postures. Then there's, you can do it where you're bent over with your hands on your knees. You can do it on hands and knees, sort of similar to a cat-cow position, seated postures, lying down postures, some that are asymmetrical with our arm positioning. There's 3 levels. Like if you get certified in the program, there's 3 different levels that increase in sort of challenge as you go. But I generally start everybody on their back first in a gravity neutral position. Then we progress into a seated or upright posture. Generally, people feel the lift most in the standing bent over with your hands on your thighs. Or if you're in, I always call it the prayer position, almost like if you were praying to Mecca. If you're on your hands and knees and you put your forehead down on the ground with your hands, because you're in a gravity assisted position, you now have your bum in the air and you're on a bit of an angle. So those positions generally are where people will feel it best or most effectively. But the idea is we want to challenge, just like we would with diversity of what we eat. We want diversity of movement as well. We want diversity of positions and postures that we would go in for hypopressives as well.
Very good. And you offer so much in your Buff Muff course. So can you explain that and tell our audience how they can get that? I know we'll put links in the show notes too.
Mm-hmm.
But so that Buff Muff course is a few month long program.
It's right now the Buff Muff, it's a membership, and people can choose to come for a month or a year at a time. Most people join for the year, and they get sort of like a fundamentals, pelvic health 101. What is prolapse? What is incontinence? What are the symptoms? What are all the root causes? Posture, hydration, constipation, all the things we've talked about here. We go into more in depth. Then it's teaching you the core breath, layering into movement, giving you some daily workouts. And then I have 28-day challenges where you're incorporating that and getting you in that habit of that 10-minute routine. And of course, I want people to be able to do more than just this 10-minute routine. I want people to be able to lift heavier, to do some impact, to get some explosive movement in there, because it's really meant to be a longevity program. And I believe that pelvic floor is is the catalyst for us to be able to have better longevity. So we come in and we address that first. And then as you progress beyond that 28-day challenge, there's a level 2, there's a bone health challenge, there's a hypopressive challenge, there's releasing tension challenge, all sorts of different workouts that people can choose from. And with the intention of this is going to improve not just your pelvic floor health, but your bone health, your heart health, your brain health, your all the health.
All the health, sex span, health span, lifespan. It's all so important.
Yes.
I love talking about this. One of my favorite topics to talk about, because there's so many ways we can empower women in their health and to recover from really powering through some very uncomfortable situations for a very long time.
Yeah.
And to reclaim that, to feel that empowerment again, feel stronger and feel more vital is critical. And we want no limiters on our quality of life.
Yeah.
Right. Our spirit's young and energetic. So let's, find the tools. And for everyone listening, you're listening to this podcast for a reason. I encourage you to check out Kim Vopni's Buff Muff membership program. And Kim, how can people get a hold of you?
Thank you for having me, first of all. Vaginacoach.com is my website, so you can learn more about me and my history and what I offer there. If you go to social media, at Vagina Coach is where I am on all the different channels. I also have a book called Your Pelvic Floor, so that's a way that you can also learn a little bit more about you, your body, and you can then take that book and you can pay it forward and give it to somebody else. And I also have a podcast as well called Between Two Lips.
Love it. Thank you. Thank you so much for being on the show today. And for all our listeners, pelvic floor health is key to our optimal health. It really is. And I'm always learning too, and understanding the right ways to optimize, to layer on movements, etc., to increase the efficiency of our workouts, our movements, etc., and that it works for us and not against us, especially when it comes to bladder issues, incontinence issues. And again, the pelvic bowl, our incredible anatomy that keeps us upright and comfortable. So I encourage you guys to check out the vaginacoach.com, thevaginacoach.com, to learn all things about Kim, and definitely follow her on social media. She will be wearing very funny workout pants that are anatomically correct. And she's always a wealth of knowledge and a pleasure to learn. So thank you all for listening. Please, as always, any questions, comments, email us at team@drannakabeca.com. I read all of those. I do read them all. My team forwards them to me. So, and what else do you want to hear about? What was the aha moment? What are you implementing today based on the information you received today? Remember, there's always one next right step to take, and I encourage you to take it. Thank you for listening. Be sure to share this episode, and I will see you next time. This is Dr. Anna Cabeca.
Thanks for watching another episode of the Girlfriend Doctor podcast. Check out all the links below for more.